this afternoon. This is Matthew Menendez with White Plume. We certainly appreciate it. This, again, as Shelley mentioned, this webinar is designed for White Plume clients who are using AccelaPASS and AccelaSmart. So we're going to focus mostly on what happens with interfaces, what happens in AccelaSmart, how to get you ready and prepared for ICD-10. If you are not using your EHR for charge capture, or if you have certain providers who are not using your EHR for charge capture, do make sure you talk to Shelley about that, because there's some additional resources that we'll need to send you to make sure that you are prepared for the transition, particularly for your providers. We want to make sure that that is an easy transition for your physician. So we'll give you some tips on that today as well. One quick housekeeping note before we get started. We'll locate the GoToWebinar control panel. It's probably on the right side of your screen. One of the sections there is a questions panel, and you can use that to communicate with Shelley during the webinar today. She'll monitor that as we go, so she will try to answer as many of those questions as we go. She'll also share those that are helpful for the whole group. She'll share those with us at the end so that we can answer those for everybody. If there are any questions, if there is any feedback that you have, anything like that, use the questions panel for that, and we'll make sure that we follow up with each of you individually on those items. So real quickly, what are our goals today? What do we hope to accomplish? The first thing is we want to make sure that we give you real practical strategies to protect your physician's time, right? To protect your physician's time so that you can understand how to make sure that you do that, and also how to make sure you protect the revenue cycle. We're going to spend a fair amount of time talking about the revenue cycle today because most of you are already capturing that data in your EHR. All right? We also want to provide you with the tools that you need to understand the impact to your particular practice. One of the things that we do in order to facilitate that is ICD-10 conversion analysis. We'll walk through that with you today. If that's something that you don't have or something that you'd like to see, let us know. Shelley can help you with that. All right? We're also going to walk through the White Plume applied mapping. Okay? The White Plume applied mapping is how we translate ICD-9 to ICD-10. We've started with the GEMS crosswalk, but we've filled in all of the gaps that are associated with that. So we'll talk about that a little bit, show you how that impacts what you sometimes see in the application. Okay? Then we'll also go through and talk about how to customize the applications to make sure they work the way that you need them to work, right? Coding is part art, part science. That's certainly true in ICD-9 and in ICD-10. There are places where reasonable people can disagree. And we want to make sure that we show you how the tool can be flexible for you so that you can make those types of preparations over the summer so that that's not a fire drill at the last minute. Because at the end of the day, what we want to make sure that we talk about is the goal is ultimately ICD-10 productivity. Many people mistake ICD-10 as a pass-fail test. They're aiming for ICD-10 compliance, which is important, but we have to be able to go a bit further than that and make sure that you're productive in an ICD-10 world, that you've really thought through your workflow, that you're doing that the right way. Just a couple of quick points of background information about ICD-10. White Plume, we try to think about this a little bit differently than a lot of other people and look at what makes ICD-10 hard, particularly for the physician practice. And how is that different than what a lot of other countries who've already moved to ICD-10, what they've seen? The first thing that makes ICD-10 really tricky is it's a one-day conversion, right? The date right now is Thursday, October 1st, 2015, right? That means there's no transition period. There's also no grace period, right? So every encounter with a date of service, September 30th, 2015, you have to use ICD-9 codes on. So you cannot go to ICD-10 early. Then when you go home, hopefully get a good night's sleep, come back in on Thursday morning. Those encounters with a date of service October 1st or later, you have to use ICD-10. It's not an optional program. There's no grace period. You have to do that quickly. And the thing that makes that even more difficult is this is not our first ICD-10 conversion date, is it? ICD-10 has been delayed 3 times already, twice by CMS, most recently last spring by Congress. It's like the boy who cried wolf. You have a lot of people who are dragging their feet, are hesitant to work on their transition plan for fear of wasting time and money working on ICD-10 when it might get delayed again. It's like the boy who cried wolf. The government has lost their credibility in this, but if you remember at the end of that story, who was it that ultimately paid the price? It wasn't the boy. It was the sheep, or the sheep owners, as the case might be. Who pays the price if your practice fails to prepare for ICD-10 because the government lost their credibility in saying, no, we really mean it this time? It's your providers, it's your owners, your management team that will ultimately pay that price. So we want to make sure that everybody's prepared, but recognize that's a difficult part. It's hard to get people to pay attention to that, and it's hard to get doctors to pay attention to this. Most doctors wish that ICD-10 would just go away, right? They don't see a lot of value in that for them or for their patients, and they've got a fair point there. The doctors don't want to change because they're still working, for the most part, in a fee-for-service world. And the issue with that is you cannot ask them to slow down. Asking your doctors to slow down because of something like ICD-10 that is an unfunded mandate, there's no additional revenue, is very, very difficult in our world. And that's what makes it different than the transition. A lot of other countries who've already moved to ICD-10, their providers were basically government employees, where ours are small business owners. They cannot slow down, and most of them don't have the interest in even slowing down in advance to learn a little bit about ICD-10, right? That's where it gets very difficult. They put that burden on the administrator, on the billing manager, on the ICD-10 project manager. You've got to figure out a way to keep them productive in ICD-10 without a lot of upfront training. And then the last piece is what's at stake. What makes ICD-10 so difficult here is that 100% or nearly 100% of your cash flow is at risk as a result of ICD-10. By law, all HIPAA-covered entities have to move to ICD-10. So this is not an incentive program. It's not a government bonus program like e-prescribing or PQRS or even meaningful use, right, where you could get a bonus or maybe eventually a penalty if you did not comply of a percentage of your Medicare or Medicaid reimbursement. No, ICD-10 is for all payers, and it's 100% of that cash flow, not a 2% penalty. So there's a lot that's at stake here. Now, for anybody in family practice, peds, and certainly orthopedics, if you have any workers' comp or auto collision carriers, they fall outside of HIPAA. So if that represents any of your encounter volume, you need to ask those payers two questions. Number one, are you moving to ICD-10? Since they're not required by law, you need to find out, are they going to go to ICD-10 or not? And then secondly, you need to ask them, when are you moving to ICD-10? Because it may or may not be on that same October 1st date. I'll show you how we handle that within the White Plume application in AccelaSmart, but it's something that you need to think about. You need to understand how your payers are going to treat that, and then you also need to understand how your EHR vendor is going to handle that. Are they going to make sure and help you capture the right code all the time, or are they only going to capture ICD-10 codes? Are they only going to capture ICD-9 codes? How is that going to work is an important question to ask your vendor as well. But it's not just about getting ICD-10 codes out on a claim. That's ICD-10 compliance. What we're aiming for is ICD-10 productivity that says we get the right code, we get it coded correctly the very first time so that we can get reimbursed correctly the very first time. And that's tricky. You know the hoops and hurdles you have to jump through in order to get claims paid in ICD-9. You're going to have to do the same thing in ICD-10. And that's where AccelaSmart can really make that transition much better for not only your revenue cycle employees, but also for your providers. So where do you start? Where do you begin? The place that we recommend is looking at the codes that you use today, the codes that are most commonly used in your practice. And we can help you with that. when we look across our client base, what we typically find by specialty, you see a pretty tight distribution of code use. Most practices use between 200 to 300 codes per specialty, and those cover 98+% of their encounters. And one of the things that you'll notice, those are very common codes, right? You're never going to see those crazy codes that always get a lot of attention in ICD-10, like a subsequent encounter due to flaming water skis. That you're not going to need that. You're not going to use that in ICD-9. You're not going to use that in ICD-10. So focus on the codes that you use today, and then see how they translate to ICD-10. It'll give you a good indicator of what areas are going to be more or less difficult in ICD-10. So here's what we did. We take those codes, we convert them using our White Plume applied mapping into ICD-10 codes, and here are the results. So you'll notice two things here. Number one, the increase is significant across specialties. And then number two, orthopedics is by far the outlier, right? ICD-10 will be more difficult for orthopedics than any other specialty. So if you're in a multi-specialty organization, or if you have some orthopedics, or if you use some injury codes, so fractures, sprains, strains, things like that, that's where you're going to see the biggest change in the increase in the code set. But we want to go with you a step further, because not all codes are converted equally into ICD-10. We put those into 3 different categories of low risk, moderate risk, and high risk. So let me walk through that just a minute for you, and I'll show you some examples. Low risk codes, that means there's one code in ICD-9, and it matches up exactly with one code in ICD-10. Now what you'll see for most practices, this is no more than 45 to 50% of the codes that you use on a day in, day out basis. So it's a good start, but it only gets us part of the way there. Okay? The majority of the codes, most of you will probably see the majority of your codes fall into the moderate risk category. And that means there are between 2 and 10 choices in ICD-10 for each corresponding ICD-9 code. The high risk category, those are ones that have 11 or more choices. You'll see each specialty has some of those. Obviously, orthopedics typically has more than the other specialties. Okay, so that's a helpful place to start when you look at that. You look at the numbers and you say, we're going to have to do something different. We can't just keep doing everything the same way we're doing it today. What's going to change, and how are we going to make those changes? One of the places that I would recommend starting, if you've not done one of these conversion analyses yet, we can do that for you. We can help you with that. And here's the good news. There's not a charge for that. Our clients will do that conversion analysis for you at no charge. So what you need to do in order to do that is send us an Excel file with your most commonly used diagnosis codes. So let me bring up an example for you. You can see this in Excel. If you are interested in getting that information, you can, again, communicate with Shelley through the questions panel. That'll put you on her follow-up list to make sure she gets that taken care of, or you can certainly reach out to her directly via email. So what you'll see is it gives me the summary data up at the very top of the screen here. 246 codes in ICD-9 and 1,147 codes in ICD-10, and it breaks them down into those low risk, moderate risk, high risk categories for me. That's helpful from a high level perspective to get an idea of what am I dealing with here. But I think the most valuable part is what's below, the line by line detail that takes each diagnosis code and shows you how it translates into ICD-10. So you can see cough is an easy one, 1-to-1. And it gives you the description, which also shows you where the new area of ICD-10 specificity comes into play. So that you can see carpal tunnel syndrome, 1 code in ICD-9, turns into 3 codes in ICD-10. Now I want you to notice something here. Look at what you see. You see 3 choices, 3 different descriptions. It's a fair amount of information to read through to choose which one may be appropriate for this patient. But look at the first one. It's sorted by code. And the first one is carpal tunnel syndrome of an unspecified upper limb. That is something that you need to be careful of. There are many, many, many unspecified codes in ICD-10, and that is a great risk. It's a risk in the short term, it's a risk in the long term, and you need to make sure you understand how your practice wants to handle that, how your EHR vendor is going to handle that. Is it going to enable our physicians to select unspecified codes? Can you customize that and not give them those choices? Because in this example, everybody has a left arm and a right arm, but there's no such thing as an unspecified arm. How is that going to be handled in your applications? How is it going to be handled in your workflow? And then also think about if that's not handled well at the point of care, we'll show you how to use AccelaSmart to make sure that we catch that error, catch that mistake quickly. So the two risks of unspecified codes. Let me talk through that with you for just a minute, because again, that's going to make a difference in how productive you are in ICD-10. The first risk is the short-term risk. The reason we're moving to ICD-10, the reason the payers are supportive of this, is they want the additional detailed information that ICD-10 provides. They want the more granular diagnoses. Why do they want it? Well, my suspicion is they want to use that data to decrease healthcare expenses over time. Payers certainly have an incentive to do that. So what's going to happen when you provide them with unspecified codes? How is that going to work? How are they going to respond? And how are you going to handle that? The concern is, in the short term, the payers will deny claims where you're using unspecified codes when there are more specific codes that should be used. That's the concern. Now, we've seen that borne out in some of the early end-to-end testing results, where payers are starting to deny claims because they want more specific information. And you've got to make sure that you're prepared to fight back against that. Now, the long-term concern is as we transition away from fee-for-service towards pay-for-performance, you're going to need to use the more specific ICD-10 codes. Use those codes to show how sick your patients are so that you can maximize your reimbursement and make sure that that's going in the right direction. So a lot of people are trying to use the transition to ICD-10 as an opportunity to make sure they are using the most specific code possible, because there are plenty of unspecified codes in ICD-9 as well. Okay? So I would encourage you to do the ICD-10 conversion analysis. Let Shelly know. Get her the codes that you want us to do the conversion for. We'll make sure we get that back to you. And I'd share that with your colleagues, and I'd share it with your providers. Because a lot of times what it does is it relieves some of the tension. It relieves some of the pressure. Many people think ICD-10 is going to be impossible, or that it's going to put them out of business, or that it's going to cause them to have to hire a lot of additional employees. We don't want that to happen. It doesn't have to be that way. You can be well prepared for ICD-10. And this is a good starting place so that you can show your coders, your billers, your providers, your management team, these concepts are not unfamiliar to us. Cough is still a cough. Carpal tunnel syndrome, we have to say which arm it was. Pain in the joint, a bit harder, 31 choices. We've got to be more specific anatomically. We also have to make sure we specify the laterality. Again, it helps to relieve some of the concern. I don't see any codes on here about flaming water skis. I don't see any codes on here about spacecraft accidents or being bitten by a macaw. Even though those are all valid ICD-10 codes, you're never going to use them. Okay? The ICD-10 conversion analysis, I can't recommend that high enough. And then what you do with that is you start to look into your workflow and see how that's going to be handled. How am I going to create those codes in my EHR? You want to ask your vendor, how is that going to work? And you want to make sure they show you very specific examples. Don't let them show you all the low-risk examples. Make sure you put in some of the moderate and some of the high-risk examples as well, because that makes a difference. We've seen this. Many of our clients have not seen how their EHR vendor is going to handle that yet. I would encourage you to push them on that and continue to ask those questions. But some of the concerns come from what we've seen from some of the vendors who have made that available. And many of them are handling it through a code search process. And there's a problem with that. And you just need to make sure that you think about how that is going to be handled for your particular providers. Will they be able to do that and do that correctly? Code search lets me start with a blank slate. It lets me put all 69,000 codes of ICD-10 into a database, and the user can search for them. That sounds like a good idea, but the concern that we have seen as it relates to code search in ICD-10 is that it takes a long time for the user to find what they're looking for. Or else, the user doesn't spend a lot of time and ends up selecting an unspecific code that requires back and forth between coders and providers downstream. And that's what you don't want. You don't want a lot of that back and forth, having your providers spend time answering coding questions instead of spending time with their patients, or answering those questions at the end of the day, right, instead of spending that time with their family. On the low-risk examples, like if you search for plantar fasciitis in ICD-10, you're just going to get one search result, so it's not a big deal. That's why you want to go past just the low-risk examples and go a bit further. Okay, so again, you're back to a blank slate. If you search for something like osteoarthritis of the knee, right, you may get 11 search results. And this one, if you look at it sorted by code, right, what that shows me are all of the choices. Now, the problem is, the instructions for this would be a lot like an SAT test, right? Read through all of the choices and choose the most right answer. There are still places in ICD-10 where it's not as specific as clinicians would like for it to be. But that's a lot of reading to read through all those choices. So hopefully, and we see this in some of the better EHRs, that they have a drill down approach, right, that lets me, it shows me the categories so I can specify whether the osteoarthritis is primary or which side it's on, and so it'll drill me down to a more specific code. I've got a higher likelihood of getting to the right code that way. I've got a higher likelihood of selecting the right code. The problem with that is it's more clicks. If you've got doctors who are click counters, this is where you might get some pushback. And it's not your fault. It is not your EHR vendor's fault. ICD-10 is more complicated. Okay, and we have seen some people that have kind of already started with ICD-10, at least in the background, and they've gotten some pushback on that. So that's an example of one of those moderate risk examples, in the 2 to 11 choices. Let's look at a high risk example real quick. Since I was picking on orthopedics earlier, I'll use an example of theirs for a fractured distal radius. One code in ICD-9. With this search, I'd get over 792 codes in ICD-10. That's a lot of scrolling. That's a lot of searching, right? And you look and see that it's sorted by code. What's at the top? The unspecified codes. And what's at the top is really important because Google has trained us to expect one of the first 3 search results to be what you're looking for. And that's not necessarily true. So again, the drill down approach might be more helpful here so that I can specify the episode of care, the type of fracture, the healing type, the laterality. I can drill down through all of that information to get to the right code. And that's important because my billing team needs the right data in order to get a claim paid correctly and completely the first time so that we protect our revenue cycle. Now, if you do have doctors who aren't using the EHR for that, or you think once you see and make sure your vendor shows you how this works, that's not going to work for you, okay? You can if you do have that problem, and I certainly hope that you don't because we're kind of running out of time on that front, but if you do have that problem, do talk to Shelly about it. AccelaCapture, the electronic superbill, is designed from the ground up to make that very, very easy for your providers. So when they click on a diagnosis code, the old ICD-10 code, they get a pop-up, and I'll show you what this particular example looks like. They get a pop-up. It defaults it to the initial episode of care. The next time that patient goes back, it'll default it to a subsequent encounter. It's organized it in a way that puts the type of fracture on the vertical axis, the laterality across the horizontal axis. So there's easy to recognize the pattern, select just one code, and it doesn't even show them the choices for that unspecified arm. Okay, so that we believe should be and is the gold standard for making sure you select the right ICD-10 code the first time and making that very, very easy and fast for your providers. So hopefully you'll see something that approaches that in your EHR solution when you look at those high-risk examples. Just make sure that you take that conversion analysis that Shelley will get you so that you can make sure that they show you some of those examples and not just the easy ones. Because you want to make sure you understand how that's going to work for your providers. Because if your providers can't get your billers good, high-quality data, there's going to be a lot of back and forth communication. And a study that was done by the advisory board in Canada looked at how much time those doctors were spending answering coding questions as a result of ICD-10, and the results were between 45 and 90 minutes per doctor per day. And in a busy practice, in a fee-for-service world, that is entirely unacceptable. So I know our focus today is not on the providers, it's not on the charge capture, but I do want to give you the benefit of that information so that you make sure you ask your vendor the right questions, so that you make sure it's not only going to be compliant, but it's going to be focused on ICD-10 productivity. Now, it is a one-day conversion for your providers, but let's think about the revenue cycle. Let's think about the billers and coders for a second, because it's going to be a big change for them as well, right? And it's not just a one-day change. Because what's going to happen on October 15th or October 30th, when you start having claims come back, they're going to have to make sure that those claims were paid correctly, follow up on anything that was denied, make corrections, make adjustments. And that's going to be a high change environment. Denials are expected. CMS has already come out and said this. The end-to-end testing results from the first quarter are bearing this out. Denials are increasing by about 200 to 300%. They're going to double or triple in the short term as a result of ICD-10. Let's think through that process, and I'm going to talk about some of the tools that White Plume provides to make that available for you, to try to help you fight back during that transition. From a very high-level perspective, you get paid for the CPT codes today. You have to have a diagnosis code that makes it medically necessary. That's true in ICD-9. That's true in ICD-10. Right? If only it were that easy. Right? If only it were that easy to make sure that you got paid. You have to jump through all the hoops and hurdles that the insurance company puts out there in order to get those claims paid and get those claims paid correctly. And then on top of that, not all payers handle that the same way. Medicare wants it one way, Blue Cross wants it another. United wants it like this, and Aetna wants it like that. Again, we've lived in that world for the past 30 years using ICD-9. And yes, there were changes from month to month and quarter to quarter. But the volume of change was relatively small. It makes it easy to keep up with. And sometimes, since the volume of change is small, people can develop some bad habits, right? Hopefully, you are updating your quarterly coding content every quarter when we send that out. Hopefully, you're building in lots of custom rules to make sure that you handle things that are specific to your payers, your practice, your providers. But if not, let's start to make some of those corrections right now. Let's do it in the ICD-9 world before it gets even more difficult in ICD-10. Because here's what's going to happen. On September 30th, your process could be exactly the same as it is today. But when you come in on October 1st, that is a massive one-day change right? Think about it. The cat and mouse game is going to change entirely. You're still going to play the game, but the details of the game are going to change. The rules of the game are going to change. And again, not all of your payers are going to handle that the same way. Remember, the payers have never done ICD-10 before either. This is new to them. They're going to also be making adjustments as they go. And that's where ICD-10 is really a marathon, not a sprint. It's not just a one-day change from a revenue cycle perspective. As the payers adjust their adjudication algorithms, as they get more data in, as they make changes, you're going to have to respond to those changes. That's the details of the cat and mouse game. And again, not all payers are going to handle that the same way, nor at the same pace. So what you're going to see here, the volume of change is going to be much higher than anything we've seen in our careers. And you're going to have a good combination of people, processes, and technology to make sure you protect your revenue cycle. So the questions we have to ask are, who's going to manage that on my team? What types of tools do they need in order to manage that? How are they going to manage those changes? And then maybe the more sobering question is, what happens if they don't? Or what happens if we don't? What happens if we don't do a good job with that? What happens to your revenue cycle? Okay? Again, it's a marathon, not a sprint. And if you're going to run a marathon in October, you want to start getting in shape for that now. And some of you probably are. You're doing a good job, you're eating well, you're exercising regularly, you're working out, you're running 30 miles a week, getting ready for this marathon in October. But some of you may not be. And it may be an opportunity to take a look at this and say, where can we make improvements? Where can we make changes that'll be better for our practice, better for us now in ICD-9, and ultimately better for us during the transition to ICD-10. So the process that we would recommend putting in conjunction with how you're using AccelaSmart today is what we call closed-loop denial prevention. And I'm sure many of you have probably seen this before. You've probably heard this before. But I'm going to say it again. We would love to rid the world of denied claims so that it never happened. But I think that's an impossible goal. We want to get as close to that as possible. When you see a new denial, when you see a new policy from one of the payers, go through this process. Go back to the beginning. Understand what went wrong. And then figure out, how do I build a new rule to make sure that that doesn't happen again? Again, a lot of you have been building these rules over the past 10 years. Since the code scan days, you've been building in these types of custom rules. They're very, very valuable. But you're going to have to build them at a much faster rate because the payers are going to change so quickly. So instead of trying to communicate through an email or through a note card or a sticky note, build a new custom rule in AccelaSmart. That makes sure the next time that exact same scenario occurs, whether it's in 2 hours or 2 weeks or 2 months, that rule is going to fire the exact same way every single time for every single employee. Whether it's my most senior certified coder or my newest billing clerk, they all get the same actionable information in order to make sure that they can get that claim paid correctly and completely the first time. Okay? So how is that going to work? Well, there are really thinking about AccelaSmart and AccelaPASS, there are really two parts that you've got to think about. Number one is getting on the right version, right? The ICD-10 version is AccelaSmart, AccelaPASS 5.1 or higher. 5.1.5 is the current release. It is available now. It has been through QA. It has been through beta. It is in the field. You can upgrade to that whenever you are ready. If you need help with that, if you've got questions on that, let Shelly know. She can get you in touch with the right people. Once you get on that version, then you can do some of your ICD-10 testing, right? You'll be able to go through and actually see what that's going to look like, how it's going to work in ICD-10. I'll show you today, but you'll start to see how that's going to work. Now, one of the key questions for our AccelaPASS clients is, how are your doctors, how is your EHR going to be sending that data? Are they going to send ICD-10 codes? Are they going to send ICD-9 codes? Are they going to send both? What's that going to look like? How's it going to work? Our interface can handle that regardless of how they send it. We should be able to handle that for you. But you do need to make sure you consider from a workflow perspective, if you do have an EHR who is assuming that they're going to continue to send an ICD-9 code, who is going to turn that into an ICD-10 code downstream? Our application in AccelaSmart can help you with that, but you still need the clinical information to be able to use the specified code. All right, so once you get on the right version, you'll at 5.1, once you talk with your vendor, you'll be in good shape, ready to do some test processes. The second part is really about the guts of AccelaSmart. The core coding content, the CCI rules, the medical necessity guidelines, the LCDs, the NCDs. We will continue to update that on a quarterly basis. We send those out to you now. You will continue to get those. Continue to make those updates. The July update is going to have much of the ICD-10 coding content in it. Now, there's still some information that we're waiting on from Alpha 2, that they're waiting on for the Max. You won't have all of that content in the July release. You will need that October release. We are working with them to make sure that we get that to you before October 1st. That's all of the core coding content. But what about your custom rules? What about the things that you have built in for years and years and years? Let me walk through that with you. Because part of the upgrade to 5.1 is going to migrate your custom rules from ICD-9 to ICD-10. You can run that when you convert to 5.1. It can also be run later on demand. What it does in your AccelaSmart Validation Rule Manager, it's going to create a new subfolder under the custom rules. That's called ICD-10. And you see that we sort that out into the 1-to-1 or the low-risk codes. Will have their own folder, and then the 1-to-many, so the moderate risk and the high risk, would both be in the same folder. So what it does is it looks through each of the custom rules. Now, many custom rules may have nothing to do with the diagnosis code. So it is just, when I see a CPT code without this modifier, I want you to stop me and let me know if it's one of these three carriers. That rule doesn't necessarily need to change. It should still fire correctly in the same way in ICD-9 and in ICD-10. But when you've got a rule that has a diagnosis code in it, that's when we have to do the rule migration. So let me go through a couple of examples, show you what that's going to look like. I'll also show you how you can use the ICD-10 conversion analysis as a tool to know which custom rules you may want to tweak or change. Okay? So let's look at a low-risk example first, right? And remember, when you look at the conversion analysis, the low-risk examples are the ones that only have one ICD-10 code for each ICD-9 code. Cough is an easy example for primary care. So when you have a rule like this in ICD-9, cough cannot be a primary diagnosis, you look at the rule expression and you see that 786.2. That's obviously the ICD-9 code. The rule migration is going to convert a new rule for you with the right ICD-10 code based upon the white plume applied mapping, what you saw on that ICD-10 conversion analysis. But there are a couple of things that are different here. The first thing is you'll notice that this rule is disabled. It's not going to fire immediately. And that's really for two reasons. Number one, coding is part art, part science. There are places where some of you may disagree with our white plume applied mapping. And we want you to be able to have an opportunity to review these before you turn them on. And the second reason is obviously nobody's going to be needing to do any of these ICD-10 rules until October 1st. There's not a real reason for us to turn all of these on for you day one. We don't want them firing right now. And we don't want to waste any of the processing time looking for these types of problems when you shouldn't be finding any. Right? If you did try to use an ICD-10 code today with a date of service of what's today, April 13th, you should get an error message that says, hey, this is an ICD-10 code, and the date of service doesn't require ICD-10 yet, doesn't allow ICD-10 yet. So that's the first change. And don't worry, if you do need to enable all of these rules all at once, there's an easy way to do that. You can do it in probably about 3 clicks to turn all of them on. The second thing you'll notice is the rule expression has changed, right? It replaced the old ICD-9 code of 786.2 with the new ICD-10 code. Okay, again, you'll see that corresponds with the data that you saw in the ICD-10 conversion analysis. That's another thing you can use this ICD-10 conversion analysis for. You can look through, you can review that, looking only at the codes that your practice uses, and see if there are any places where you've got a question or you've got a problem with the white plume applied mapping. Those are the ones that you might want to pay particularly special attention to in the rule migration. Okay, and I would encourage you, do that work over the spring and summer. Don't wait till the last minute to do that. Okay. The last change that you'll see on the new rule is that we put it into a category for you where you can see that it's ICD-10 migration. That's really just to make it easy for you to organize so you can know where that rule came from, how it got created. Okay, pretty simple, pretty straightforward for those low-risk codes. Let's look at a more complicated example. Okay, the moderate risk, the high-risk codes where they have multiple ICD-10 choices. Okay, let's look at this one. Here's an example where you've got, it's a revenue mining rule. This practice was looking for missed revenue opportunities. They knew when they saw male patients over the age of 50 with a kind of an annual Medicare physical that they should also be doing a prostate check with their annual exam. But sometimes they didn't bill for it. So they built in a rule to try to find that. When I see this diagnosis code, this procedure code is missing, this is the gender for the patient, right? This is the patient's age. How does that get migrated in ICD-10? Very, very similar, right? New rules created, still disabled. Now look at the rule expression. The rule expression is a bit different. What's different is, look at that first line. When the encounter diagnosis is Z00.00 or Z00.01. So rather than looking for just one code, it's now looking for one in that potential string of codes. You'll see that it'll look the same way whether you have 2 choices or 10 choices or 30 choices. It works the exact same way. It's still going to put it into that ICD-10 category for you. But there's one other change that I want to bring your attention to on this particular example. If you have the diagnosis code entered as text in the error message or in the expanded error message, it is not going to change that for you automatically. So those are ones that you may want to review and correct as appropriate. Again, something that you don't have to wait to the last minute to do. You can be reviewing that over the spring and summer. Okay, I hope what you'll see here is we're making sure your core coding content is kept up to date, ready for ICD-10, and we're making sure that your custom rules are migrated automatically so that you can review those and make sure that those are correct as you head into ICD-10 this fall. I'll show you one quick item on AccelaSmart. I'll bring up just a quick screen for you here. What you'll see, this is AccelaSmart 5.1. It should look very familiar to everybody. What I'm going to show you is everything's the same here. The one thing you see that's different is up at the very top, I've got ICD-10 codes in my diagnosis block. And look at the bottom left-hand corner. What you'll see on this particular rule is it says Blue Cross Blue Shield, this particular insurer, pays reduced reimbursement when we use one of those unspecified codes. Isn't that sneaky? They didn't deny the claim entirely. They just paid us a reduced rate because I didn't specify which ear. We should know which ear the patient was complaining about. And so you'll see in the custom rule, It gives them not only what's wrong, but it tells the user the 4th and 5th digits in ICD-10 for the left ear, for the right ear, for both ears, right? Tells the user not only what's wrong, but what they can do to correct it. That helps protect your revenue cycle in ICD-10. It helps prevent your coders from spending a lot of time going to look up a new ICD-10 code. Now, yes, they still have to make sure that you've got the documentation that backs that up. That piece of it is always true. But again, we're trying to put the right tools in our billing team's hands so that they can make sure they get those claims paid completely correctly the very first time, so we don't have to hire a lot of additional billing staff, right? That's what we want to be able to do. And so I want to make sure that we equip you with the right types of tools to do that. We would highly, highly, highly recommend, if you're not in a good pattern of identifying denials, building in a new rule to make sure that they don't happen again, start doing that now. Start doing that now in ICD-9 so you'll be better prepared to handle the changes and the volume of changes that are coming this fall. All right, now last slide, and then I'll answer as many questions as I can before our time runs out this afternoon. So if you've got other questions that have been burning a hole in your pocket, go ahead and send them in to Shelley. But I want you to think about what you want your practice to look like in October. Think about what you want your back office, your front office, your doctors, what do you want their experience to be in November of this year after ICD-10? Is the target simply compliance? Or are we aiming for ICD-10 productivity? And what does that look like? What do those two things look like? Compliance looks like the ability to send out claims with ICD-10 codes on them. May or may not be the right codes, but they're ICD-10 codes, right? Productivity says we've really looked through this, we've thought through this for our practice in particular, and we're making sure that we optimize our workflow, not only for our providers, but for our billing team as well, right? Because I want to protect my doctor's time and doctor's productivity so that they're not staying late to answer coding questions, because most of them did not get into healthcare, did not go to medical school to be a certified coder. That's not what they're interested in, and that's not what they're good at. And that's not what the business or their patients need them doing, right? Our doctors need to be focused on taking care of our patients. That's what keeps our patients happy. That's what keeps them coming back. And our billing team, they need the right code the first time so that they're not having to work overtime, nights, weekends, just to get claims out the door. And make sure you've got a good, well-tuned process in place, that closed-loop denial prevention that we talked about, building the custom rules in AccelaSmart to be able to respond to the changes that come from the payers. Okay? Because we don't want to, there's no additional revenue to hire any additional employees to deal with ICD-10. Right? There's no additional revenue for ICD-10. That means if we have to hire any additional staff to handle this, we're going to be less profitable than we were before. And that's the concern. That's the concern that we have for a lot of practices that says if they haven't thought through this, they're just going to end up having to hire more employees to deal with it on the back end. And at the end of the day, they're going to look around and say, gosh, we are doing the same amount of work for a lot less profit than we used to. And they'll chalk it up to increased government intervention and bureaucracy and frustration of the code set, and all those things are probably true. But it doesn't have to be that way. Leverage the tools that you already have in place to make yourself more efficient than you are today. I hope that this has been helpful for you. I know we've covered a lot of ground and we've moved through this quickly. All right, we're going to answer as many of the follow-up questions as we can right now, but this is not your only opportunity to ask questions. Feel free to reach out to Shelley anytime. We want to work with each of you to make sure that you have a very smooth transition to ICD-10. So thank you for being great clients, and thank you for your time this afternoon.